Okay, so we're talking about treating MS in the time of COVID. Essentially, just a few bits of information. My main practice is at Christian Barnard Memorial Hospital. I've been in private practice since 1996. It's a long time. And Lon's quite right. I have an interest in seeing my MS patients. It's been a long journey. I've walked with a lot of my patients for more than 2 decades. The next thing is I've started a practice on Fridays. I work in Robertson at the Carewell Hospital. In fact, right now I'm sitting in Robertson in the Carewell Hospital. Not in the Carewell, at my place of residence in Robertson. So if you hear lots of birds and farm machinery going on, that's the local farmers. That was a picture yesterday morning from my rooms in Robertson with snow on the Langeberg. So we are really in the middle of winter down here. I'm fortunate enough to have had 2 offices with beautiful views. And on Monday, I posted a picture literally from my Cape Town office with snow on the mountains. So we really are in a cold spell down here. Okay. Starting off with an article that was published last year that has kind of influenced my entire approach to managing my patients with multiple sclerosis during this time of COVID. Gavin Giovannoni, some of you will know him. He qualified at Wits University as a neurologist and now has a MS-based practice in the United Kingdom, is an excellent reference, and he's an amazing speaker, both on a medical level and on a patient level. And I follow most of what he says. I think he's an amazing speaker. So essentially, I'm going to talk about disease-modifying therapy during the time of COVID, and I've based a lot of my experience on what he's said, some of which I will add as my own personal opinion, but I'll tell you what's my own personal opinion added to this as we go along. All right, so Gavin divides the drugs into various risk categories, and the risk is of developing serious COVID infection if you're on treatment. And the first group he groups together calling very low risk. And these you'll all remember as our so-called first-line therapies in South Africa, often called first line, mainly because they're less expensive and have less long-term side effects. I've listed them in no particular order. The first lot are the interferon betas, and there I've listed them simply alphabetically: Avonex, Betaferon, Plegridy, and Rebif. All of them the interferon-based therapies, which are very low risk. In other words, if you're on these treatments and you should develop COVID, by low risk, I'm not specifically meaning interferon, you should have low risk of developing more severe illness. Glatiramer acetate or Copaxone is on this list, and so is Aubagio or teriflunomide. My personal approach has been all my new patients that I've diagnosed during this period. I've looked at these as my starting point, which we always have to, as they are first-line therapies. But at the beginning of COVID, when we didn't know quite what was happening, there were some studies suggesting that interferon beta would help improve the condition of patients. And as a result, my approach has been to inform my patients of all 3 treatments, the risks obviously involved with them, but I have mentioned to them that there were some early studies, none of which carried on, that interferon beta seemed to be useful in the management of COVID symptoms. It didn't carry on being used, but obviously cost, and there were better options later. So it has somewhat influenced my choice. The second thing is patients who've failed on first-line therapies, I've often gone to a second first-line therapy during this period based on keeping patients at a very low risk. Obviously, in pre-COVID times, someone who failed on a first-line therapy, we would immediately consider drug escalation, but I have been a little more conservative simply because of the risks associated with it. Just by the way, excuse all the birds, there's lots of birds around here. Right, the next group are the 2 low risks. Let's start off with our old faithful, natalizumab or Tysabri. That is a low risk. Those of you who use it know it's a once-a-month infusion, and the risk is it's a low risk for coronavirus, not obviously for PML if you are JC virus positive. The exciting thing is that natalizumab has now come out as being safe in pregnancy. I'm not going to do a separate pregnancy thing. I'm going to mention the drugs that are probably safe in pregnancy. I'm just going to go back one slide, as I neglected to mention. Copaxone in outside of South Africa has had the pregnancy contraindication removed. And obviously there is some evidence that interferons are also probably going to be safe in pregnancy, but at this point, glutaric acetate and Tysabri are safe. So if you're on Tysabri, contrary to our previous beliefs, you now can continue with Tysabri during pregnancy. Obviously, you would discuss this with your treating neurologist. We're very excited that we will soon have Tecfidera or dimethyl fumarate. Obviously, not a lot of. I personally haven't had a lot of experience. I'm luckily enough have 3 patients that used to, well, before COVID times, used to fly between Germany and South Africa, spending their summers all in Germany and their summers in South Africa. And 3 of these patients were on Tecfidera, which was extremely well tolerated by them, and it seemed to work extremely well. Very excited to be able to be using that one of these days. These are low risk, not very low risk, but obviously fall within the realm of low risk of developing serious COVID disease. We then come to the intermediate risk, and the intermediate risk is associated with possibly having a prolonged viral shedding. In other words, the virus will stay in your system longer, you will be infectious longer, and you might have longer illness should you be on one of these drugs. The first is a category called SIP modulators. I've used that term simply because the one we have available commonly at the moment is Gilenya, fingolimod, or the one we use in this country is called Tuvagen. And the second one that we'll be getting soon, I'm also very excited about this, is siponimod. So we will be having more than one of these category drugs. The next group of drugs that are on intermediate risk are those of the anti-CD20 drugs. Those are the B-cell therapies. The one that's available in the country at the moment is ocrelizumab or Ocrevus. And the one I've added this because it is being used by some people in this country, and that's rituximab or Mabthera. It is not registered for the use of multiple sclerosis in South Africa or anywhere else, but is commonly used in Scandinavia and certainly has been used by neurologists in this country to treat MS where there are various indications that it might be indicated. Also intermediate risk, which is quite exciting, is cladribine or Mavenclad, which is one of the newer drugs that will be very exciting to be using in the future. So these are intermediate risks drugs. The high risk, and these are the ones that probably we'll be avoiding at the moment, and they cause immune depletion. And that's the part of the situation we're scared of. The first one is I've really added for historical purposes and because Gavin added it to his article, and that's Nivantrone. A lot of my patients got it many years ago when we had no other choices. In fact, one of my patients commonly renamed it Smurf juice because of this blue infusion. Mitoxantrone, probably not used anywhere anymore. The other drug, which is very potent and does amazing things for treating MS, is alemtuzumab or Lemtrada. That, however, is a high risk. And then clearly what is definitely a high risk will be stem cell transplant, HSCT. So these are the high risk situations. This combination of things has probably changed the way a lot of us have treated our patients recently, taking less risk in our patients right from the beginning. Then I found a very interesting article by Fitzgerald et al. On Neuro Today online, and I thought this is quite important. How do patients with MS fare with COVID-19? In other words, what happens if you have MS and you get COVID? So the 2 conclusions they drew, and I'll give you some more information after the slide, but their main 2 conclusions were that MS patients are most likely to get critically sick if they had an ambulatory disability. So those patients whose mobility was influenced because of their MS, and I'll explain a little more on the next slide, certainly had bigger problems and got sicker with coronavirus. The rest of the risk factors were identical as the general population. Okay, this is one of the slides Ashvina kindly supplied me with, and I've got a few in the presentation which you will see. But essentially, this comes from pooled data from Italy, France, North America, in other words, global information looking at the risk factors. I'm going to initially exclude the MS risk factors, and we'll come to them at the end. But the standard risk factors for having severe COVID in the general population, which is the same as in MS patients, is the older patients, males get sicker, obesity. Interestingly, obesity seems to be a very high risk factor in general with COVID virus. The last one right at the end, race and ethnicity, it seems in some of the European and North American studies that patients of African, Black origin seem to do a little worse. Then you'll see the second last risk factor there, recent use of methylprednisolone or anti-CD4 therapy. So patients on anti-CD4 therapy that we've already dealt with, those are ocrelizumab, rituximab, and one or two others that we don't have here. But the other risk factor is that of methylprednisolone. As a result of this and understanding that patients on very high dose steroids were at risk of developing more serious COVID, this is now a personal observation, I've been a little more careful about giving intravenous steroids for milder relapses. So if you've had a sensory relapse of an arm or a leg or a mild relapse, I've probably kept a bit more conservative, not necessarily giving high-dose steroids. However, in severe relapses such as bad optic neuritis or a cerebellar attack or those kinds of attacks, we have no choice but to give IV steroids to enhance the recovery. The last, or the middle two that I'll come to, bear once again with the ambulatory risk. In other words, people who are more disabled. So your higher EDSS score, you all know that, and we probably love to hate that evaluation. The EDSS score is purely based on your ability to walk. That has influenced our ability to treat our patients for years because the EDSS score rates your disability, and we haven't found another score, which sometimes we have to fight with our funders to get care for our patients. Progressive MS course, once again, this is associated with higher disability. Okay, now the hot topic, vaccines. Once again, I think you need to understand there are different types of vaccines, and different types of vaccines react differently. So this lovely slide, and I'm not going to get into great detail, but I want you to look at the 4 main types of vaccines. So you get what's called a live attenuated vaccine. In other words, this is a vaccination there where you injected with a live organism. The next slide, I'll give you some examples, but a live organism that's been made weaker, but you are injected with a living organism, and this induces a very strong response. The second is an inactivated virus. In other words, the virus is no longer alive. And then you get a subunit vaccine where part of the virus, and then you get the toxoid. The toxoid is where a toxin is used. So some examples of these. We commonly have had in fact, probably all South Africans have at least 2 or 3 of these. The live attenuated vaccine, tuberculosis, we probably all had our TB vaccinations. Oral polio, those drops you get as a child, 3 lots of them. And then MMR, measles, mumps, and rubella. The tricky one, and I'm probably going to come up with 2 of these as tricky ones in treating our patients, where you talk about risk factors. I'm going to quickly do this as an aside from COVID because it is a topic that I think is relevant to vaccination. Yellow fever vaccination. So, all right, so we were talking about yellow fever vaccination, and probably varicella zoster as our patients get older is going to be another question. But yellow fever vaccination, I've always had a frank discussion with my patients, because if you're simply going to go on holiday to a place where you need a yellow fever vaccination, perhaps it's easy to review where you're going to go on holiday to and not take the risk of having a live vaccine. However, if you're going for work, or if you're going to be relocating to a country, that is something that has to be taken in consideration and managed. probably a lot of us have had yellow fever vaccination. The next are inactivated viruses and subunits, of which you'll see a whole lot of examples here: hepatitis, rabies, pneumocock, hepatitis B, and then tetanus. These are all really considered to be tolerable and safe for people with MS. That doesn't mean it can't trigger an immune response, but it is not going to make you abnormally ill. So you don't have a risk for getting sick, but an immune response one can always trigger from one of these vaccinations. Okay, this is a very busy slide, but it's extremely useful because what this slide is just put on to show you is where the various vaccinations we have in South Africa stand, where the ones we're probably going to get stand, and where the ones we're possibly going to get stand. So if you have a look, the first one on the top left-hand corner is the Pfizer vaccination, and it is exactly, well, not exactly, it's a similar base to the Moderna, which I'm going to present some information on just now. So those two are RNA viruses. In other words, they are not live viruses. They're RNA vaccinations. They're not live vaccinations, so they are safe. They're non-replicating viral vector. That is the Johnson & Johnson and the AstraZeneca, which we know the story of the AstraZeneca vaccine in South Africa. What is important is right at the bottom, you'll see the Gamaleya or the Sputnik vaccination, which we may or may not get in the future. And I've added this because I thought it's important, is also a non-replicating viral vector. In other words, it's a similar basis of vaccination to the AstraZeneca and the Johnson & Johnson. Then lastly, I've just put on here that also an inactivated coronavirus is the Sinovac. So the Chinese vaccination will be a similar inactivated virus. So just for those of you who are quite reassured by the information I'm going to present following this, the Sinovac and the Sputnik will be also inactivated virus. These are not live viruses. All right. I've based the next part of the talk on the risk factors of the indications, the guidelines for treating patients with vaccination. And this is from the National MS Society, and that's the article if you want to look it up. This is based on American data, but I think it's really useful to interpret worldwide. So this article is based on vaccination in patients older than 12 and only for the Pfizer, the Moderna, and the J&J vaccination. Obviously, we don't have the Moderna here, but the Pfizer and the J&J are the two ones that we are likely to get. And all this information is relevant to those patients. And obviously, data is normally collected in older patients. And most of you will probably agree with me that we don't commonly see MS under 12, although it's well described in children. Okay, so first of all, as already said, I'm sorry there's a bit of repetition here, but I think it's important because of the fear out there. None of these contain live virus, so there are no live viruses here. They are not likely to trigger an MS relapse. It doesn't mean it's not possible, but it's very unlikely. And that's an important reassuring feeling for patients that you are not likely to have an MS relapse, and they are unlikely to have an impact on disease progression. This is a very important information because the last statement, and this is the statement of this article, excuse the farm implements going by, the risk of getting COVID-19 far outweighs the risk of the vaccination. And I think this probably, of anything I say today, I think this is the most important slide for me, is that the risk of vaccination is much lower than getting sick from COVID. And I'll talk a little bit more about that at the end. I've got some other information that I want to share with you. So, quite important here is that some of the disease-modifying therapies may make the vaccination less effective. And this is important, particularly with Ocrevus and Lemtrada, as well as Mabthera, because these interfere with your B cells, and your B cells, those of you who understand a bit of immunology, your B cells are there to make antibodies. Your T helper cells are there to help with the immune response. So what happens is, if you're on these forms of treatment, your timing of your vaccination, you still need to be vaccinated, but your timing of your vaccination is essential. I'm not going to give details here because I don't think there's a lot of patients on these drugs, but those patients on these drugs need to discuss with your treating neurologist what the timing of your vaccination, particularly if you're getting 2 doses, when to have the first, when to have the second, to time it so that you have the best immune response. In other words, these drugs might make you have less an effective vaccination, so therefore you need to make your timing perfect. Okay, this is my byline, and I think this is quite important for me. I'm encouraging all my patients, as soon as your age becomes appropriate for vaccination, to vaccinate as soon as you possibly can. Why? Well, if you're on a first-line treatment and you are vaccinated and you have a new relapse, or your MRI shows you have new disease activity, it makes it very simple for us to escalate you in any way we want. It doesn't mean we are limited by simply swapping one first line for another first line. We can easily jump up without creating greater risk to you. So once again, my advice is to go out and get vaccinated as soon as your age allows you to, because I think this is going to make all of our treatments a lot easier. The funders have not got involved in this, so they haven't asked if you've been vaccinated or not at this point, but I do think that might become a question later. But at this point, please, I encourage you all to get vaccinated. I'm now going to probably spend a reasonable amount of time on one slide. This is my last slide, and I've probably spoken too fast, but I'm going to spend a lot of time here because this isn't, I base this on one article, but I'm going to talk about a lot of my experience I've had. So this is an article about a possible case of multiple sclerosis following COVID-19 infection. But what I do want to talk about before I get to there is what the neurological manifestations and complications of COVID-19 have been. We have often seen post-viral symptoms on various viruses, but probably never to the degree we've seen on COVID-19. So patients who've had COVID-19 develop a lot of neurological manifestations, either during the illness or after the illness. Our first clue probably that patients were going to have neurological problems was that one of the early warning signs that you might have COVID-19 is that you lost your sense of smell. Now, your olfactory nerve is not really a nerve, it's a so-called cranial nerve, but in actual fact it's a projection of the brain. So when you lose your sense of smell in COVID-19, that was already a clue that you probably were going to get some kind of encephalitis. So that was our first initial clue. Speaking about that, I've seen patients who have lost their sense of smell for over a year after the COVID-19 disease. In fact, one lady who had a very mild COVID literally took a year to recover her sense of smell. So that was our clue. Some patients during the course of COVID get serious neurological manifestations that get better, but a lot of patients develop their manifestations afterwards. This includes mild COVID as well as serious COVID. So people who are mildly affected, that are home for a couple of days and get better, as well as those who have been in ICU and required ventilation, can develop quite significant disability after having coronavirus infection. The most common one I have seen is that the so-called post-COVID headache, where you have coronavirus infection, you recover, and you're feeling fine, and then you develop the most dreadful headache, and that headache can last weeks. It's not too difficult to treat. There are things to do for it, and I normally use a drug called amitriptyline, cheap and easy, and most patients improve, although I've now got 3 or 4 patients with resistant post-COVID headache that we have not been able to get under control despite multiple interventions. So that's probably the most common one I see. The second most common neurological symptom, and I think these are all important, the next lot are very important for our MS patients and why I'm encouraging you to get vaccinated. The one is severe post-COVID fatigue, severe fatigue. Now, I don't need to speak to this audience. You all understand that fatigue is probably one of our biggest problems with MS. People without MS who develop COVID develop severe fatigue, unable to carry on with their daily work, exhausted all the time, and this can last months. Very difficult to treat. There is something we treat this with, something you'll all know quite well, Provigil. It's a drug that helps with the fatigue. Obviously, this is an off-label indication. You know, those of you who've used it for your fatigue with MS know how well it works. It works extremely well, but yeah, it does help these patients, but the fatigue is a big issue. The third most common thing I'm seeing, and this is a devastating side effect of COVID-19, is cognitive impairment. Literally, I've had to book multiple patients off of work for prolonged periods of time. And this is not just someone who's fatigued, someone who's tired, someone who's a little forgetful. We've gone to the degree of having neuropsychological assessments, neurocognitive assessments, which prove patients are unable to continue working at this point. And I have at least 4 or 5 patients that I can think of right now that we've had to book off for the next 6 months that are unable to continue with their daily work. And these are patients who had minimal COVID, weren't even in hospital. Once again, Provigil certainly does help for these patients. So there are things we can do to improve it, but not to the degree of getting back to work. Yeah. So those are the 3 common ones I see. Then we get to the things that are probably relevant for our MS patient group. And those are, how does COVID affect myelin? Which I think we all know that MS is a disease where you have demyelination. The first one that we're seeing more and more commonly is Guillain-Barré syndrome. Now, to understand, Guillain-Barré syndrome is a peripheral demyelination. So the myelin in the peripheral nervous system is formed by Schwann cells. It's a different form of myelin to what you find in the brain and spinal cord. So Guillain-Barré and MS are completely different conditions, but patients following COVID or even during COVID have developed Guillain-Barré syndrome. These are patients that have often had mild disease or severe disease, followed by the typical manifestations. So Guillain-Barré typically in adults would present as an ascending paralysis. So you lose power in your feet and it slowly creeps up your body and you become progressively paralyzed. However, in children, it often presents as a painful sensory symptom, and that's probably more of what we're seeing in adults at the moment, is a sensory Guillain-Barré syndrome, a severe burning of the feet. Nerve conduction studies and all the rest of the tests confirm this. And these patients, at least 2 or 3 that I've seen recently, are wheelchair bound because of the severe pain. Recently, in fact, I was contacted by a colleague who 2 weeks after getting relatively mild COVID ended up in a wheelchair with Guillain-Barré syndrome. So this is not an uncommon manifestation. It's not common, but it's not uncommon and quite devastating. The second, some of you might recognize that word, ADEM, or acute disseminated encephalomyelitis. This often, when we newly diagnose an MS patient, is in our differential diagnosis. So if you present with quite severe disability in your first attack and your MRI shows lots of demyelination in your brain and spinal cord, we often wonder whether you have MS at that stage, or if this is a one-off disease called ADEM. We are certainly seeing that in patients with post-COVID. Meningoencephalitis, I think that's a relatively more common one, although this article only described 1 or 2 cases. But we're certainly seeing patients with confusion, kind of a meningitis type picture following COVID or during the acute COVID picture. What is important in this particular article is that they describe a case that's highly suggestive of relapsing, remitting multiple sclerosis following COVID-19 infection. Now, obviously, this could be coincidental. As it just so happens, I have seen 2 patients who have Parkinson's disease, so-called developed after COVID, but there's no way you can be sure that there's relevance until we get more information. But they present a patient who had COVID, then had a neurological symptom, showed an MRI with demyelination, and at a period later had an optic neuritis. So whether the COVID triggered it, or this was just coincidental, hard to find. The reason I'm presenting this particular information is, first of all, take COVID seriously, and secondly, I was spurred on by interest on looking at this particular situation by one of my patients who was doing extremely well on her first-line disease-modifying therapy, and subsequently after COVID had a relapse. And it was a long debate we had whether this was a relapse or whether it was COVID-induced demyelination. My feeling is one couldn't take the risk this was simply COVID. One had to approach this as though the patient had had a relapse and change therapy. Right. Time for some questions. If I've spoken too fast, I do apologize, but I certainly hope you have lots of questions to ask me, and I am open to presenting as many questions as you like.
Thank you very much, Doctor. I think Ashvina will now help me to identify these questions. There's a lot coming through on the chat.
Great, thanks, Nan. Thank you, Dr. Opperman. That was really good information that you've provided to the patients online. And we can see the questions are coming through fast and furious. So one of them is the vaccine safe for any neurological issues such as epilepsy?
So yes, certainly it's safe in epilepsy. I've encouraged all my epileptic patients to go to have it. I've encouraged all my patients to do this. Only time one has to be careful is if you're on any immunosuppressive drugs. That's when you need to time this very carefully. But I've encouraged everybody to do this because I've seen the devastation COVID has caused.
Okay. And someone wants to know, what is the better option to treat fatigue? Is it Nucon or Provigil?
I absolutely believe in Provigil. It's about a cost issue. Provigil, you know, in South Africa we use 100 milligrams once a day. I was lucky enough to have spent some time in Canada in the early 2000s, where they used 200 milligrams in the morning and 200 milligrams at midday with amazing results. I think it's a great drug. If anybody's used Provigil, I personally have used Provigil if I go to a conference, because it allows me to focus for 6 or 7 hours and listen to speakers and enjoy the input I get. So I think it's an amazing drug. You don't have any uncomfortable feelings, and it doesn't cause the agitation. So that would be my first choice. But Nucon is affordable, and I certainly do use it in a lot of my patients.
I don't know if this is going to take up much time. Someone wants to know pros and cons of taking the vaccination.
Well, I'll give you the perfect con. A colleague of mine ended up being in hospital for a year and 2 months, on a ventilator for a year after getting COVID. I mean, devastating. At this point, this is not a neurologist, but a colleague of mine, a colleague I'm very fond of, still is on oxygen at home and now can manage to climb 4 steps. This is a devastating disease, absolutely devastating. I'm not saying MS is not devastating, it's equally devastating, but this is something that is preventable. And I really encourage everyone to get vaccinated. I'm vaccinated, my staff are vaccinated, and I think personally it's a no-brainer. We have to be aggressive here.
Okay. That ties in kind of with the next question. One of the attendees has had or thinks they've had a mild case of COVID. It was in the home setting. And obviously now from that experience, they're quite terrified of getting the vaccine. What would be your words of wisdom?
Well, I think anyone who's already had mild COVID, the vaccine is ideal, because that means so to understand the process of developing immunity, if you've had mild disease and you get vaccinated, all you're doing is re-triggering your immune response. So you are making your antibodies stronger, your immune response stronger. that's why if those of you who are reading a lot, you'll know that the Johnson & Johnson is a 1 vaccination, the Pfizer's a 2 vaccination. There's now a debate in the United States that you might have a 3rd vaccination or be vaccinated by a different brand. So if you've had mild disease, I encourage you, you're going to probably get the best response. Bear in mind, after the vaccination, you might get normal vaccination results, a little bit of muscle ache, a little fatigue, that kind of thing. But certainly if you've had mild COVID, I think you're going to probably have the best result.
Okay. In relation to pregnancy, one of the attendees is on Tuvagen, trying to fall pregnant, 1.5 months in, got a first relapse without any medication. Wants to know, can I take Tysabri to prevent another relapse while falling pregnant? And then obviously, is it safe to take the COVID vaccine as well in pregnancy?
COVID vaccine and pregnancy, that's a tricky one. That's a really tricky one. I personally would get vaccinated before you fall pregnant. Absolutely. Pregnancy is a very complicated thing with vaccinations, but I would certainly, anyone on this meeting intending to fall pregnant, or your friends without MS, get vaccinated before you fall pregnant. I think that's important. We don't know what COVID will do during pregnancy. So if you develop COVID during pregnancy, we don't know what the complication is going to be. That time will tell. So that's answering your first question. Secondly, the SIP modulators are tricky. So they're quite difficult drugs to stop. So Tuvagen is a wonderful drug when it works, and it really does work well, but stopping it is often associated with a relapse, and it's quite difficult to manage. So yes, a Tysabri is an option, but that once again depends on your JC virus status. That's something I would discuss with your treating neurologist, but if you positive JC virus, and we can look at titers and things to work out risk factors, that is something to look at. Obviously, if you, this is now highly technical, if you're JC virus negative, it's probably a reasonably good idea. If you're JC virus positive, then it gets quite technical, and this is probably not something for a general discussion, but there's this what we call a stratified risk factor. So the shorter period you use Tysabri, the lower the risk of developing the complications of Tysabri. And what one can do is when you do the JC virus, we can get your level, and that can work out how risky it is. And if you're going to use it for a short period, your risk is lower, but it's not risk-free. So hopefully that answers your question.
Okay. Dr. Opperman, the time lapse between getting the vaccine and, getting the COVID-19 and then to have the vaccine, what period should you wait for?
I think that's quite tricky, and it depends on how ill you were. I don't know that there's specific data on exactly this. Ashwina, if you have any more information than I'm happy to listen, but I probably would wait until you recovered, and then I would get vaccinated. So as long as you're feeling good, probably at least 6 weeks. We know that the first vaccination, if those that are having more than one vaccination, although in South Africa we probably prolonged the period, probably for logistical reasons, not for the indication, it's been a month apart. So I probably would not get vaccinated for at least 4 weeks after I was recovered.
Okay, ivermectin. Your opinion on using ivermectin?
Shall we go? I'm going to reinvent the wheel. Those of you who've been involved in MS as long as me, and you're not going to burst out laughing now. Do you remember the bee stings to treat MS? Patients would go and get stung by bees every day. We need science. We can't rely on anecdotal evidence. And if anyone looked at Eyewitness News today, if you go on EWN and have a look, all the information on ivermectin's been thrown out because of bias in the study. There's no evidence that ivermectin works. I'm not saying it does you any harm. You probably get rid of all your parasites, but I certainly would not use it as a treatment, or definitely not as an alternative to vaccination.
Okay. So it's kind of mixed in terms of the questions. I just want to pull out, since we are discussing around the vaccinations, just to try and look at all those questions first before we deal with the others. So I'm not leaving you out in terms of your questions not related to the vaccines. Let's chat around the vaccines and then we'll pick up on the other questions thereafter. So, Dr. Opperman, do you think we will need annual vaccines in the future as the virus is mutating, obviously?
I honestly have quite strong opinions about this. I honestly feel if the whole world had been vaccinated in one fell swoop, we probably would not have had so many variations. So if it had been possible for everyone to get vaccinated in the first 3 months of vaccines being available, I think things would be different. That's a personal opinion and probably quite a biased opinion. Yes, I do think there's probably likely to be an annual vaccination until such time as things come under control. I mean, if we look at the mutation and we look at influenza virus, we know that every year, if you're going to get vaccinated against the flu, you need a new shot every year. So it probably is going to be a booster shot every year. It just makes logical sense. That's my gut feeling.
Okay. In terms of mixing up vaccines, one of the attendees would like to know, they've just had the Pfizer vaccine. Would you recommend that they could take the J&J when it's available?
I don't think anybody can answer that at the moment. That is what's being looked at. It's being looked at, should one mix those? Those are the two prominent ones being mixed. And in fact, the other is mixing the J&J with the Astra. We have no evidence for this at the moment. So I certainly cannot recommend it at the moment, but keep your ear to the press. I do think this is going to be very useful information that will be coming out soon, but at the moment, there's no definite information.
Okay. I'm not too certain, maybe you will know, doctor. If I take the vaccine and I have a negative reaction, do I go directly to my neurologist? Will a negative reaction be due to the MS? I just need a bit of reassurance.
Okay. So it all depends on the negative reaction. I had my vaccination and I had a really unusual side effect. One or two of my patients have had the same thing. I had hot flushes. I understand what menopause is like. I'd be sitting in a crowd and suddenly there was sweat pouring down me for 10 minutes and it cleared up. It was quite bizarre. For that, you certainly don't need to see your neurologist. But if you have a neurological manifestation afterwards, then certainly contact your neurologist, because I think then at that stage it's worth getting an MRI and making sure you haven't had a relapse, either from probably coincidental or from it. But I do think if you have, and you all know your MS symptoms, anything that lasts more than 24 hours that's new, or a bad flare-up of something that you've had in the past. In other words, something you've had in the past mildly, like maybe a tingly foot, and now your whole leg is feeling strange. So something that lasts more than 24 hours that's either new or worse than what you had before, certainly contact your neurologist.
Okay. We've had a few queries regarding Tuvigen. Is it safe to take the vaccine while on Tuvigen?
You must take the vaccine while on Tuvigen, absolutely. So absolutely so you need to be vaccinated, in my opinion, irrespective of what treatment you're on. The only ones where there's a timing issue is going to be the mabthera and the ocrelizumab. Those are going to be where there's a timing issue, that you've got to do it at the right time. All the rest, I think you need to be vaccinated. The question is going to be, is your vaccination going to be as effective? But yeah, they certainly need to be vaccinated.
Okay. I've been diagnosed with multiple pulmonary emboli. Is post-COVID, as a post-COVID symptom, sorry. How safe is it to have the vaccine? So, yeah.
So we know there are vascular risk factors. And that is one of the big issues of the vaccination. It seemed to be mainly the Astra one that had the big problems, but there's certainly others do as well. I think when you're talking about multiple pulmonary emboli post-COVID, I would then chat to your physician. This is not a neurological question. This is because either your pulmonologist or the physician that treated you as to what your other vascular risk factors are. And also, if you're now on treatment to prevent thrombosis because of your emboli, you should be a relatively low risk at that point.
Okay.
Just quickly, you know the risk factors for this. I mean, it's been looked at in quite great detail that if you're on HRT or on the oral contraceptive, you have more of a risk of developing thrombosis than if getting the coronavirus vaccination. So the COVID vaccination is less of a risk than simply being on HRT or the oral contraceptive. So that simply answers your question. Hopefully that information helps you.
I am on Tysabri. What vaccines are recommended? How long after or before the infusion date should I take the vaccine?
Okay, with Tysabri, you're fine. You have your vaccination as your date comes up. There's no problem there. Remember how Tysabri works? It doesn't affect your immunity at all. It just blocks those horrible little soldiers from getting into your brain and attacking you. So your soldiers are all out, as I like to call them. Your immunity is perfectly intact. The Tysabri there's no timing issue.
Okay. Also with Tysabri, JCV positive, taking ivermectin occasionally every 2 months. How long should I also wait for the vaccine? So it would.
Tysabri, get vaccinated, seriously.
Okay. And then we kind of going into a little bit more general. There's a question regarding numerous issues with my teen, starting from when I was around 9 and my teenager, I think it was, starting from around 9 years old. He's now 15, and I recently was diagnosed with MS. Is it possible that my teen could be having it already?
So, sadly enough, a good few years ago, some of you might have read the South African MS guidelines that were originally published a long time ago. I was one of the co-authors of that article, and I met an amazing pediatric neurologist from Durban, and she presented data of the youngest case described that was 6 weeks old of having clinically definite MS at the time. So we know that MS can present at any age. It's just uncommon. The youngest patient I ever diagnosed was 11 years old, but I don't treat children. It just happened that her father was a patient of mine and asked me to help out because there was a misdiagnosis. So yes, it's quite possible. Familial MS, it occurs. It's relatively rare, but certainly worth looking at. At that age, I don't know where you live, but probably either at 15 can probably see an adult neurologist, or wherever you are, see a child neurologist. There are pediatric neurologists all over at the moment.
A question concerning the sort of in-between period between reimbursement funding. So I'm not currently on a DMT. I'm in the waiting period with the funders. What advice can you give me?
That's easy. I've had such a horrible fight recently. You know, funding normally goes through pretty smoothly these days for everything. I've had a huge fight with one of them where my unfortunate patient literally waited almost 2.5 months, and that was with daily fighting. And what solved it was nothing I did, it was the patient. Start off by phoning them all the time, followed up by sending emails. And if you don't get a logical response from your funder, you should not be waiting a month for an answer. But if you don't get an answer within a month, there's a magical word called the ombudsman. Just deal with it that way. We as doctors can only do so much. We are not contracted to your medical aid, so you have to carry a little responsibility. So I do say, from your side, fight. We fight hard. We have a whole team that fights. The drug companies, the pharmaceutical companies aid us in this. But if we have a 3-pronged approach and all 3 of us agree, I think there'll be better results.
Okay. There's just one regarding, is it possible to be treated with medoral at home or to take oral cortisone instead?
So there's no evidence that oral cortisone works. It has been used mainly by ophthalmologists for optic neuritis, for milder optic neuritis. Solumedrol it's intravenous. In fact, if you look at the older stuff, they're using ACTH, which is the predecessor. So some of the original articles. If you have a bad relapse, you should rather have Solumedrol. If you've never received intravenous Solumedrol before, then you need to be in hospital for at least your first treatment. It's unusual to be allergic to steroids, but I've had some patients who've had an adverse reaction to Solumedrol. If you've had Solumedrol before without any bad responses, I have during Corona time, and in fact prior to it, I've treated lots of patients at home. It's convenient. Depending on your medical aid, it's fully reimbursed, and it's very convenient. So it's an easy way. And in fact, during this period, that's how I've treated most of my relapses, mainly because a lot of our hospitals haven't had room to put patients in during bad peaks of COVID.
Okay. We're almost coming to the end of the questions as well. And there's just one here. Is it true that Epstein-Barr virus can play a role in triggering MS?
So that's that's everybody's hobby horse. What triggers MS? Well, there's certainly some evidence that Epstein-Barr, and that's a whole. In fact, when I go to an MS Congress, if I can find the Epstein-Barr meeting, it's always quite entertaining because there's lots of to's and fro's about it. The theory really is that if you develop Epstein-Barr virus for the first time as an adolescent, that's when your risk is. In other words, if you get Epstein-Barr as a young child, you're probably not at risk. If you develop Epstein-Barr as a young adolescent, in other words, in your teens, you probably are at risk of later developing MS. But there's not clear evidence. The one thing they did look at was using vaccination of Epstein-Barr, and that certainly did not help at all. So vaccinating people with MS put you at the same risk. Vaccinating people for Epstein-Barr put you at the same risk of developing it. So that's definitely one of the hot topics, looking at why people might develop MS. And that's why I think that case I presented with the coronavirus might be interesting, because there was herpes 6. There's lots of viruses have been implicated as possibly switching on this unusual immune mechanism.
Okay. And this is the last one, Dr. Opperman. So I have a feeling in my feet, but do have a bit of a drop foot as well. Is there a remedy drug for cold feet? Can my nerves repair to get the message to warm my feet as such?
So we have lots of drugs, not lots, we have drugs to treat peripheral neuropathy. So drugs to treat burning, painful feet, but we do not have drugs to warm the feet. That certainly we don't. There's nothing that's going to warm the feet. There are drugs to improve gait. So we have something like Vampira that will make you walk better. But we don't have anything to make your feet stop, be warmer. No, sadly not.
Okay. All right, Dr. Opperman, I think we've covered, literally all of the questions that popped up in the chat box. If there's any